I'm waiting on the sun to rise, waiting on the moon's dim glow, looking so deep in your eyes, wishing that time would slow.
Hello, everyone, and welcome to this evening's episode of the Black Scientists Cooperative. Tonight, we are doing something really exciting. We're going to be talking about how to own your health. So, how to take charge of your health, how to advocate for yourself when you're in those doctor's appointments, and be able to ask the right questions. So tonight we have a very special guest with us, someone that is very near and dear to my heart, Dr. Octavia Peck Palmer. And so, we're going to open it up and I'm going to let her tell a little bit about herself and how she came to be.
I
Welcome,
want to
Octavia.
first well, thank you so much. I want to first thank you all for the opportunity to spend some time with you all today and talk to your audience. So, my name is Octavia Peck Palmer, as Dr. Patterson Smith noted, and I am a clinical chemist. I'm from a small town in South Carolina, did undergrad at an all girls school in South Carolina, did my doctoral work where I was looking at the pathogenesis, which really just means how something forms. In the realm of infection and in sepsis. That's what I was really focused on because I realized even back then that Black individuals had a higher rate of becoming septic compared to white individuals and even Hispanic individuals. And from there, I did a postdoc in St. Louis, and I have been now an associate professor for the past 12 years in the Department of Pathology. So really appreciate having this opportunity to share with you all today.
That's great. Welcome.
Welcome.
It's good to see you.
Yes, welcome, welcome, welcome. So, with that, Octavia, can you explain to our audience, tell us a little bit about what laboratory medicine is and the role that you play specifically?
Yes, so laboratory medicine has really just been thrown into the spotlight because of COVID-19. People really weren't aware that laboratories exist and they are the ones that produce the results that your physician uses to actually determine, send you home, keep you in the hospital, give you drug X, Y, or Z. And so laboratory medicine really is defined as the science of measuring substances that are in any type of body fluid. And that can be blood, urine, it could be the fluid that's in your spinal cord. If you're going to the doctor and you've got a swollen knee, the fluid that comes out of the knee. Those measurements are then used, they're interpreted by your physician, by your nurses, your other healthcare professionals to make decisions on how to manage your care or what to do next. So I am a clinical chemist, and clinical chemists are doctoral or medical degree individuals who have had a couple of years of training following getting that degree. And they serve many capacities. They can direct clinical laboratories that serve humans or animals. They develop tests. Many of us are aware of glucose testing that some of our family members have to do on a daily basis. They develop those type of devices for testing. They develop skin creams. They develop shampoos. And so clinical chemists can be in various areas of science. They include individuals who read the toxicology report. So if you're looking for a certain drug, they're the individuals that read the test to see if you are pregnant. So clinical chemists really do play a role in various aspects. And I'd like to end on the note that it's just not the clinical chemists. There are medical technologists that are in that lab. They are the individuals that run those instruments. So it really is a community in that clinical lab. And although we're not seen by the patients, your physician uses the results that we provide in order to manage your care.
Okay. Thank you for that. Because I'm pretty sure that a lot of people aren't aware of this field of medicine and what role it plays in their healthcare. And so, as we think about healthcare, we understand that in many cases, Black people experience certain diseases and certain conditions at a disproportionately higher rate than other groups. And so we tend to call these, refer to these things as health disparities. But can you explain a little bit more to our audience about health disparities? And another phrase that sort of comes up sometimes is this phrase, health inequities. Are health disparities and health inequities the same? And can you talk a little bit about that for us?
Yes, so that's a great question. So, health disparities and health inequities are interdependent. So, they do depend on each other, but they're actually separate entities. And so, when we think of health disparity, we think of a difference of something. Black individuals have a higher rate of diabetes than white individuals, that difference. When we think of health inequities, we think of some type of injustice, some unfairness there. So, Black individuals do not get tested for prediabetes as often as white individuals. So, the disparity there. What I'd like to add to that is that health disparities and health inequities are actually really just long term effects that have come out of these complex systemic bias and racism that we've seen. So there are policies that have been developed, that have been put in place and have been used. And this is why we continuously see health disparities. Many people publish papers. I've done that myself, where I want to link it to some type of biology, some type of gene that say, oh, Blacks, harbored this more than white individuals. But there's a complexity to a gene being turned on. I know you all understand that. Your environment. Do you smoke? What is your diet? And so when we really think about a health disparity, if it's a difference, could it be that I just need a ride to the doctor? Could it
Yep.
just be that I need to know when to get my mammogram so that I don't have a higher content? Could it be that
Yep.
I just get the right test ordered so I'm on the right medication so I don't wait till I'm in stage 4 and then in hopes of trying to get some treatment then? So it really is so complex, and we really need to focus on what we can do with policies, what changes that we can make, and how we can advocate for ourselves and our families, because it's going to take a lot to dismantle this systemic racism that has compounded what we see now with inequities.
Yes. Oh, I like that.
Mhm.
I love the way you just explained that. I mean, it makes it very plain, very clear. And I think it brings the idea that something that we don't think about in terms of health disparities, that in some of your papers, you've written about that there are actually health disparities that can be demonstrated in laboratory medicine itself, right? So, how can, or I guess maybe the question is, can, and if so, how does the practice of laboratory medicine, how can it be used to identify health disparities and then develop interventions to eliminate them?
Yes. So if you don't mind me stepping back for a little bit, because I myself was taken aback that it took me this long to get to this point of
Mhm.
understanding how I could be the cause of health disparities.
Mhm.
And the example that I want to give everyone is when we think about renal disease. When we think about renal disease, when you go to the hospital, you give a urine sample, you may give a blood sample, and they're looking for a specific substance. And that substance is creatinine.
Mhm.
Okay. What they'll do is they'll take that measurement, but add it into a calculation. So imagine you're at the grocery store, and not only are you paying for your candy, they're going to add a tax to that candy. And depending on if you're Black or if you're white, your tax might be different. And so you can imagine, if you don't have enough money to pay for that candy, depending on what your tax is, then you're either going to not get that candy and get another candy, or you're going to be able to pay for it and go home. And I put it that way only because this calculation that's used to measure how your kidney is functioning actually uses a correction if you're Black, and it uses a correction if you're white. And unfortunately, it causes Black individuals to be sicker in order to then be able to move to dialysis or to get that consultation to be put on the transplant list. And if we already have disparities in renal disease, we already have disparities in getting treatment. then if I am part of the problem that I'm adding this correction factor, I'm compounding it. And so there are a host, unfortunately, of algorithms or calculations that use this Black correction factor. And it's founded on eugenics. It's founded on the idea that Black people, either one, aren't fully human. Number two, they don't feel pain the same way. And so years ago, they would do surgeries on Black individuals and not give them anesthesia. And so, and not too long ago, there was just a paper with medical students that they asked a Black skin versus a white skin, what do you think is thicker? Do you think about the pain? And this is in the 2000s. So we have to understand that the basis of medicine, many of that was done on the lives of slaves who did not have a voice, who weren't consented. And yes, we've gotten to some really great breakthroughs, but on those breakthroughs, we've broken people. And so we have to go back and really unbreak this system and make sure that it's equitable treatment, it's equitable testing, tests are available. And so getting back to your last part of that question is that, Dr. Tillman, what we have to do is we have to dismantle these algorithms, and we have to look at them and have evidence-based medicine that says, yes, Octavia does need this because she's getting personalized medicine, not because she's getting race-based medicine.
Mhm.
And so our goal is to ensure that all areas as the lab should have the appropriate test. If I know that I have a large population of individuals who are susceptible to diabetes, then my lab should be offering hemoglobin A1C. We should be offering insulin testing and glucose. Hospitals need to be outfitted with the appropriate tests for their population so that no one falls through the crack.
Awesome. Sounds great.
So I kind of want to piggyback off of that. And, you mentioned how they contribute to health disparities. So can you give me the flip side, though? Can you give me how laboratory medicine can contribute to reducing that burden specifically? Or, anything you've been a part of, perhaps, maybe personally or, peripherally in that respect?
Correct. Yeah. And so that is the goal of laboratory medicine, is to first access. So you are a laboratorian, you have a lab, you must be outfitted with the key tests that are necessary to treat patients. You would not have a laboratory where you couldn't do the basic electrolytes. That's not a lab to me. And so there shouldn't be labs that are just focused on toxicology testing when you're trying to do the whole wellness of a person. One of the things that I have been a part of is looking at those algorithms that use race and removing them. And so I am happy to say that we have brought together a committee that in the new year will be removing the race correction factor for renal function. And we feel that that's appropriate because each person, each patient should be receiving personalized medicine. And if we think about it, how do I know if someone identifies as Black if I never asked them, if I just automatically correct for them because a health provider looked at them? What do we do with individuals who may identify as biracial? What do we do with individuals who don't identify Black or white? And so we're doing we're taking a look back and really thinking about these algorithms and how they may be detrimental. The other part of that is also ensuring that alerts. I know that you all are aware that preeclampsia is higher in Black women compared to white women, and that Black women experience higher rates of morbidity and mortality following childbirth. I mean, we're in 2021. This should not be happening. And so clinical laboratorians can actually set up alerts that as soon as we see key substances in the blood or in the urine trending high, not even being critical, but trending high, we can alert a physician. We can alert the physician to order certain tests or to look at certain results. And so our goal is to be more proactive in making sure that all individuals get the test that they need and that they don't fall through the cracks.
Can I just take a minute
Sorry.
to make this a little personal, because you just really hit home for me when you were talking about the disparities with regards to pregnancy, because I have a 9-month-old, And I had some complications during my pregnancy. And if it had not been for the fact that I have this scientific background and that I made the decision to advocate for myself, I would not have been able to have the accommodations that I needed in order to have a safe and healthy pregnancy. And I thought to myself, like, well, what if I didn't have this knowledge? So, just for full disclosure, I had blood clots in my legs during the pregnancy. And so I could not commute for long stretches and I could not sit for long stretches. And, I had to advocate. And I know that there are a lot of folks out here that would be scared to do that. It's crazy that Black women die disproportionately from something as beautiful as pregnancy because we don't know how to advocate. And a lot of times, we're not in spaces where others are advocating for us. So I just had to, stop for a minute and say, how critical and how important this is and how, it's really important, guys, that you advocate for yourself because no one else is going to do it.
And another thing I wanted to bring up, Octavia, you've used a few times the term personalized medicine, and I feel like that term is really the buzzword, and it has kind of came to light within these last, I would say, 7 or 8 years. Maybe going back a little further than that, but it was personalized medicine. And with what you're describing and what you've talked to us today about that, is it really personalized? Like, is it really, like, is that a relative term? Is that like the new buzzword here? Because if you have these algorithms as you're describing here, that's determining what my, testing treatment will be, then is it really personalized?
No. And when personalized medicine came on the scene, the idea really was pharmacology, that I would know what genes I have and I would understand how I metabolize drugs. So that way you wouldn't get drug X and not metabolize it, builds up in your system, toxic effects. Or you give me an opioid, I'm an ultra metabolizer. I'm coming to you because I'm in pain, but you think that I am just addicted to the drug now and need it, but it's because I'm an ultra metabolizer. So personalized medicine from that standpoint was pharmacogenomics, and then it became cancer, that we could develop cancers, gene specific treatments, depending upon the type of cancer you had. And so I don't believe that the algorithms are personalized, by no means, because we all know that if you base it on race, which is not a biological construct, it's a social construct. And so, what I didn't share with you earlier is that the calculation that we use in the United States, when they used it in a South African group, it didn't work. But if you're saying that all Black and African Americans should use this, I'm pretty sure if my sister from Ghana or my sister from Kenya or Ethiopia came to America, they're having their creatinine corrected for that. And so we have to be really careful about these algorithms that we have, even though they dated back to the 70s. We really have to step up and make some changes. And so you're correct. Personalized medicine means that it should be something about me, not a population that you deemed I'm from. It should be about me. Yeah.
And Octavia, it seems like your lab getting rid of these rhythms or that race part of the algorithm, that seems to be forward thinking, because I'm imagining that the majority of the labs hadn't gotten there. And is that a true assumption or not? Or is this the way that the field is heading towards, where this will become common, that those race components of those algorithms will be removed? Is that the trajectory of that field?
I would like to say that we were forward thinking, but we will be in the company of 8 hospital systems that are making this bold move. They're
Is
Beth
that around the
Israel,
country?
Vanderbilt.
Are those 8 around the country or where you are located?
No, around the country. It will be only 8 around the country by this year when you count us. And about 2017 is when the first hospital took their stand to make that change. Now, totally understand that if there are a host of consultations and a host of dialysis algorithms per se of who gets on dialysis and when they get on dialysis are based on these correction factors, then we're going to have to step back and make some decisions. And so you don't want to overtreat someone and you don't want to undertreat someone. And that is the debate there. If we remove the correction factor, then I may over or undertreat Black individuals. But I think we're at a juncture right now that there are enough Black individuals who have not received the treatment that we have enough wiggle room to step back and really give them the treatment that they deserve. So that is the debate, but it is taking off. And there had, like I said, been some front runners back in 2017, but it will probably be only 8 of us as of February, and hopefully more will join.
8.
Yes.
This is good right here. I like it.
But you know what, Lee? 8 is a start, and I'd say thank God for folks like, you know, Octavia, Dr. Peck Palmer, that are leading the charge, you know, to bring visibility to this, and the rest will follow. The rest will follow in due time, but thank goodness someone is leading the charge.
Yeah, no, it's not just this correction. I think that's what, you know, when we saw inequities in our face on television this summer, that's when other people started to move. And that's when, you know, because Dr. Vanessa Grubbs, who is a nephrologist, who has made this comment, who has shown the evidence, she is a Black doctor, has brought to our attention why it needs to be moved. And there has been years of pushback. So the debate has been going on for decades. I think it took this summer to make people really move and to see the systemic biases and racism and how it's an undertone of everything. It's an undertone of every part of our lives, and no one's sheltered from it. So I'm happy that we're on this trajectory and we have so much more to do.
So, Octavia, thinking about the policies that are in place, what existing policies are focused on reducing health disparities in medicine?
So I always like to think about the faith-based, and many of us are aware of them. Faith-based, your church, they do the health fair. This is really community-based. Yes, we have state policies, and those policies look like education for behavior. So there'll behavior campaigns, don't smoke, get your mammogram. But it's usually the faith-based groups that transport the person to get the mammogram. You know, explain to them why their health is important with cookouts and community activities. And so it has to be more of a true interaction that people feel that they're part of a community and not just a policy. There are some other things, Healthy People 2030, yes, which has already started this year. This has been an initiative for about 10 years from the government, but many people don't know about it because they don't have direct interaction. And so Healthy People 2000, the whole idea behind that was that by 2000, all health disparities would have been eliminated. Well, it's 2021, and we know that hasn't happened. And so each year, there are goals and initiatives. And this year, there's some goals and initiatives in there that allow more community-based action. And so I think it really comes down to not government-driven, but community-driven. And it's going to be things that help with our own behaviors, but it has to really help with medicine. If you look at me and you don't think I feel pain, or you look at me and you already judge me, it doesn't matter if I got to my appointment. It doesn't matter if I'm sick enough because you're using algorithms that tell you I'm not sick enough. And so I think that's where our policies are going to have to work on, training health professionals and helping professionals identify their biases, and also making sure our curriculum is not, biased, which it is.
Yes.
We're biased because we set people in boxes. We say if your cholesterol is like this, then we give you statins, or we tell you need to work out. If you smoke, then we offer you these things. And so we've set up boxes to put people in, and we need to step back and figure out how that biases groups in order to have worse health outcomes, worse health, and also not want to go to the doctor.
Yeah.
So, as we bring this all full circle, for our viewers, because I'm sure you've just about blown their mind,
Indeed.
because I know mine is blown, right?
Yeah.
Because, these are things that, quite frankly, I had no idea about these corrections, these race-based corrections that take place, when I go to give my blood, to get my metabolic panel back, right? Had no idea. So when we bring all this together full circle, what do we tell our viewers about how they can advocate for themselves, when they go into that doctor's appointment and when they're having conversations? What tips can we give them on how to approach?
Yes. So I know we like to joke about, we see something on television or we Google something and we know we have that disease, all the symptoms, they're there. But I would tell you that that's not a joke, because part of that is research. And so if you can't have a conversation with your physician that you found something on Google and they're not willing to talk to you about it, that might not be the physician you want to keep. Okay. So one is building a rapport with your physician, but then you might say, well, when I get there, I only have 2 minutes and then I forget my questions. Always write your questions down. Have your list of questions available. If you feel a pain, if you know something's not right, then you push for it. Just like you said, Mila, if you had not had that knowledge, they probably would have just completely passed it off and said it's indigestion, even though you're feeling pain somewhere else. And so you have to write everything down and continue to press the physician or the nurse about what your illness is. The next thing is always have an advocate with you. Many of us just want to go to the doctor by ourselves and we're fine, but many of us go to our doctor with our parents. And why do we do that? Because we're going to take notes, because we don't believe what they're going to tell us. Sometimes we need to have our own advocate with us, no matter what our age is, so that they can speak on our behalf. Because when you're in pain and when you're sick, that's too late by then. You've got to know what medication you're on. I can't tell you how many times that a result may come measured in the lab and it doesn't match. And we find out that grandma's been taking all of this biotin. That's the big thing right now, biotin, or there's an herbal supplement, and it can throw your test off. So make sure you're really clear about what you're taking, so that the lab itself will be able to make adjustments and interpret those results. But you don't be afraid to back down. You only have one body. It's your body. You're worthy. And you have to continue to let them know that this issue has not been resolved. And if it takes going to another physician, another hospital, you've got to do that.
And it's also, you have to tell the truth. If you're feeling a pain, if you've not, like, you have to be honest with the healthcare provider too. Like, let
You're
them know
so right, Dr. Williams.
whole
You're
history.
so right.
Like,
Mm-hmm.
you have to know that, they have to know that. So it's important to tell that you are in pain or that you're not feeling well, and you haven't been feeling well for X amount of weeks.
Right.
Yeah. Tell them so that we can figure out what's going on.
Mm-hmm.
Yeah, and your care team should be advocating for you.
Mm-hmm.
Let me tell you, my care team is blackity black, black, black. And I'm not saying that, you have to have a doctor that is black, but let me just tell you, the ones that I have, they see me as a person. They see me, that could be my mother, that could be my sister, that could be my aunt. And, a lot of these disparities and inequities tied to the fact that, even in the healthcare system, you see unconscious bias. So,
Yeah.
you need to have a healthcare provider that when you say, I Googled this and I think I might have, whatever, they're like, okay, let's take a look, instead of rolling their eyes and saying, you don't have that, I'll see you in 6 months. So thank God, special shout out to Dr. Perpetua Goodall, who is the one that took care of me when I had the challenges and pregnancies. That is my sister, and I love her, and she made sure I was good. So make sure that your health team is just as much of an advocate as you are.
Yeah, and that was actually a question that I was going to ask you, Octavia. I don't know if you've studied this or if your lab has studied this, but do you see a difference in bias when ethnicities or race of the patient and the physician are the same or similar versus a complete opposite? Is there a difference in the way that those diagnoses and tests are run? Because I think we think that, okay, if I get a Black doctor, then that Black doctor is going to advocate for me. But have you tested that, or have you seen that to hold true? Because all my doctors are Black too. So,
Well,
and you're right, Milo. They take care of you. And so you feel that comfort level. But has it been shown that there really is a difference in the way that they actually treat you in turn, medically and clinically treat you, not just like socially treat you, but in diagnosing you and taking care of you?
yeah, so I have not personally done the research, but there is literature out there that actually shows that Black patients fare better when they have patients that look like them. There is a recent article that my mom actually texted to me because I suffer from preeclampsia after having 2 healthy pregnancies. And it actually demonstrated that preeclampsia levels or rates were lower in Black women who had Black doctors. So the question is it a matter of looking more for symptoms because you're heightened and aware of the health disparity? Or is it something about the level of care that it is at the level that it should be, and that it falters when they're not in that care? And so that's the question. There is nothing biologically different about Black women that would cause us to die in
Right.
having children. And so there's something inherently wrong about how we're caring for Black women during childbirth. But yeah, there is literature out there concerning that. And that is the push for having doctors that reflect the population.
Yeah.
And there's no reason not to.
Yeah.
That's good. That's real good.
All right.
All right. Well, listen, Octavia, we thank you so much for joining us this evening. You have enlightened us, and I know have enlightened our viewers on tonight, and we just really appreciate you. We hope that you will come back and join us again at some point. And, again, just thank you so much for sharing tonight.
Well, you all are very welcome. I've enjoyed my time, and thank you for letting me share some time with your audience.
Good deal. Thank you so much.
Yes. Well, hey, viewers, thank you for coming to another episode of the Black Scientists Cooperative. We are spitting knowledge tonight, okay? So the next time you go to your doctor's appointment, have your phone ready, go to Google and ask questions.
Questions ready.
And as Octavia said, write them down. Write them down.
Right.
Write them down. So until next time, guys, we'll see you on the next episode. Bye-bye.
Bye-bye.
Deep flows like a breeze flowing through me, from my head to my feet. Your love runs smooth, ooh, it soothes, and you're making life right. I'm so glad that you're mine. You're mine. Yeah, 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 yeah.